You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Not too long ago, we used to do a full sepsis workup, labs, urine, lumbar puncture, treat empirically for every young infant with a fever under the age of 3 months. It was a lot. We felt obligated, if not a bit skeptical. Over the past 3 decades, a swell of evidence has been lapping its waves at our feet. The tide turned with a watershed article, now a tsunami of a clinical policy. From the American Academy of Pediatrics, today we will deconstruct and demystify the evaluation and management of well-appearing febrile infants 8 to 60 days old. Okay, confession time. During these past 7 years talking to you through this wonderful medium of podcasting, I hesitated on one very common, very easily confused topic, fever. It just seemed to be a moving target, and I didn't want to muddle the message. But now, the time has come. The Pantel et al. Article is such a big deal and game changer that it's time to learn the new rulebook. Bacteriology has changed. Technology has changed. We have better opportunities for improvement in care. The multidisciplinary committee, in conjunction with the Agency for Healthcare Research and Quality, used all available published data to standardize a feasible approach to the well-appearing febrile infant that optimizes specificity while still maintaining acceptable sensitivity. Just for reference, in febrile infants 8 to 60 days, about 10% will have a UTI and less than 2% will have bacteremia. Of course, that will vary by age group. Less than 0.5% will have bacterial meningitis. Vaccines did this. Vaccines made invasive Streptococcus and Haemophilus a rare occurrence. Now, E. coli is the number 1 organism causing bacteremia, with meningococcemia in second place. No one wants to miss that rare but devastating diagnosis of meningitis or bacteremia. Yet, no one wants to go through the motions that we know may be doing more harm than good. There's a lot to this, and there is some nuance. We'll do an age-based overview, and then we'll practice with some illustrative cases to get into the nitty-gritty. First, it's important to remember that this guideline is for term, well-appearing infants born without complications who are 8 to 60 days old. You're 5 days old with a fever? You get everything. There is no and should not be any guideline for you. You're just too high risk to use population measures for your care. This guideline is for infants who were born in a very boring way. They went home with mama. They're doing just fine, thank you very much, until fever strikes. Your preterm, no guidelines for you. Tailored, individualized care. Fever when you were born, maternal fever, no guidelines for you. You have an obvious bacterial source, cellulitis, omphalitis, osteomyelitis, no guidelines for you. We treat you as you are for what you already have. These guidelines are for children with fever without an explainable source who, for all anyone knows, could end up just fine or could get really sick. We just don't know, and we can't tell by looking at them, no matter how good we are. We do, however, accept the fact that these well-appearing infants initially can hide invasive bacterial disease. These guidelines help us to screen and to safeguard. The guidelines characterize age-based risk in a new way. 8 to 21 days, 22 to 28 days, and 29 to 60 days. Now you may be thinking, why do they make a separate group for the last week of your first month of life? I'm right there with you. They have their reasons, and I'll explain shortly, but you are most welcome to put them together mentally for now. So here we go. Less than 8 days, no guidelines. These children are very high risk for sepsis. Do everything. 8 to 21 days. We're trying to balance the risk of bacteremia with the risk of our workup. It just so happens that week 3 is a downward inflection point in bacteremia and risk will decline. We'll go over this breakdown and I'll give you my take at the end. But the quick version is that for this group, 8 to 21 days, nothing has changed. Do all the things. Urinalysis, urine culture, blood cultures. Perform that lumbar puncture as soon as you can. Give antibiotics without delay. Admit all of these patients on antibiotics until cultures result in a few days, and the infant has proven himself that he is doing okay. Johnny is 11 days old. He is brought in by his mother and father for feeling warm today. He was born at 38 weeks, no complications. He went home with mama on day 3 of life. He is successfully breastfeeding. He seemed a little fussy this evening. Mom feels him to be warm, so they come right in. On exam, Johnny is well appearing. He has normal flexed tone. He's breathing normally. He has good capillary refill. For all the world to see, Johnny is winning at life. He's healthy. He has caring parents. Until you get a rectal temp, and it's 38 degrees Celsius. You know what's in store for everyone from the very start. But Johnny's mama and papa need a little TLC too. We need to take them with us on this journey. If you drag this out, first some urine here, then later, oh please will you let us stick him now? I'm sorry, now we have to put a needle in his back. That's okay, right? What do mama and papa think? Can we say no? And of course they can, but that is really not the best case scenario for good informed refusal. Did the importance of the workup really match our approach? The stakes are high, so let's act like it. Here's a strategy. Compassionate determination. Every fiber of your physician core says this 11-day-old infant needs to be treated for possible bacterial invasive illness. Taking a step back, the labs, urine, lumbar puncture, they're not therapeutic. We could just give the IV antibiotics or intramuscularly for that matter. But is that the best care? Will that delay safe discharge? What if the child gets sicker? We really do need an IV line, labs, all that jazz. So, in the name of what we think is being nice and pleasant, you can soft shoe your way into the discussion with good intentions so as not to jar them. But oftentimes, you end up just stubbing your toe here when later on you tell them we need these things urgently, yet we've been taking our time getting there. Now, we've all been in this situation before. Also, parents are already scared. They're protective and maybe a little mistrustful of the big bad hospital. Compassionate determination is not paternalism. It means any doctor would know for a fact that you need to do this. There's really no debate. There's no doubt in your mind, just potential doubt in your patient's or the parents' minds. Compassionate determination is, please let me help you. I will be there with you throughout this scary time. But if we don't act, it may be even scarier, and it may be even harder to help you later. Let's do this together. That's a bit of a build-up to say we use the shock and awe approach to neonatal sepsis workup. It goes something a little bit like this. Mr. and Mrs. Smith, I'm so glad that you're here. Johnny looks well, but he's too little to leave things to chance. We will need to get an IV, send bloods, and perform an important lumbar puncture. Then you pause. You see how they're processing it. Maybe you're speaking too quickly, maybe too much jargon. Get a sense of where your message is landing. Give them a moment. And at this point, if you see a deer in the headlights look, or yes, doctor, that kind of look, if all of that seems to be something you can work with, you're making some progress. But if you see that wall coming up, you can see they're getting a little tense, they're already ready to refuse you, then you can just add this as a very neutral thing. Just take the emotion out of it and just give them the information that they need to know. You can add, lumbar punctures are safe. We do them all the time, and we stay far away from the nerves. Mrs. Smith, did you get an epidural when you were having Johnny? It's just like that, but with even smaller needle, and we go in just far enough to get a small amount of fluid, and then we take the needle out. We don't leave anything in there like they did with that little plastic tube they left for you for your epidural. Then you walk right out of that room, you assemble the team, and immediately get IV access and immediately get that lumbar puncture done. Our words should match our concern and our actions. Shock and awe. The longer you draw out that LP, the more fear and dread will fill them. Do it compassionately. Do it with determination. Moving on, the 22 to 28 day group. The good news is that the guidelines allow for treating this group like the last. You may very well choose to do everything for all infants less than 28 days. Now we're going to go and talk through some other options in this 22 to 28 day age group, depending on the workup, the resources, and the context. Enter the inflammatory markers. There are serum biomarkers that may help us to risk stratify. What are they? First, there is the big baddie procalcitonin. This little wonder of a biomarker has been shown consistently to be elevated with a bacterial infection and not elevated with a viral illness. Multiple studies have shown that a procalcitonin of less than 0.5 milligrams per milliliter is consistent with a non-bacterial source of fever. So that's one inflammatory marker. It's abnormal if it's greater than 0.5 milligrams per milliliter. Next is a C-reactive protein of greater than 20 milligrams per liter. Another abnormal inflammatory marker is an absolute neutrophil count of greater than 4,000. These are the labs that can serve as inflammatory markers, but there is one more. A higher temperature is also in of itself a separate marker of inflammation. So let's add a temp of greater than 38.5 degrees Celsius to that list. And finally, if you don't have procalcitonin in the EDE yet, you will soon, because this is becoming normal care. No procal possible, then you can use an absolute neutrophil count of greater than 5,200. To recap, we are screening for possible bacterial illness in this age group, 22 to 28 days old. If any one of those are positive, then we need to do the lumbar puncture. A positive inflammatory marker just puts them at higher risk for bacterial illness. Your screening threshold has been met. The febrile, well-appearing 24-day-old comes in with a temperature of 38.7. Bam! LP. His procal is greater than 0.5. Bam! LP. His CRP is greater than 20, bam, LP. ANC greater than 4,000, blah, blah, blam, LP. As mentioned, you can also use a higher cutoff of 5,200 for the ANC if you don't have a pro-cal possible. It's a hard week for the Smith family. Johnny's cousin Mikey comes in, and at the registration desk, they say he's a month old. When you actually count out the days since his birth, he's actually 27 days old. Mikey was brought to a family gathering, lots of oohing and awing and kissing his chubby little cheeks, and he comes to triage with a temperature of 38.7. He looks well, but you already have your diagnostic, treatment, and possibly dispo plans determined. At triage, he has at least one inflammatory marker, an even higher temp of greater than 38.5 degrees Celsius. Now, you could treat all children under 28 days the same and do everything. Mikey is 27 days old. He's almost there after all. And so in this 22 to 28 day group, we have some options that open up. There is a narrow but possible way home for this child. I know. I need a moment too. Deep breath. Okay, let's talk about this. Hypothetically, after the LP, if it's totally normal, there is no pleocytosis, no bacteria found, it's normal, you're not concerned with HSV in any way, and you find no other source of bacterial illness, Mikey still looks good. If the family can observe at home, they feel comfortable doing so, and they don't need to take 3 buses to get to see you again. And if your risk tolerance permits it, you may give the child a dose of IV antibiotics, send home, and come right back for a recheck and a culture check, and admit if positive. That's a lot. I mean, it is what we used to do in the old days, just with a 2-month-old or 3-month-old, not a 22 to 28 day old. Is this my personal practice? No. I think the 22 to 28 day option of home is asserting a distinction without a difference. To be fair, the logic from the experts is that the rate of bacteremia and invasive bacterial illness drops at that day of life on average in the population studied. So, great, but how do I use this info? And really, you should ask yourself, how are you going to use this info? I use it as a backup to tell me this is an option and help me to understand that this is generally accepted and it's okay to do as long as all those puzzle pieces seem to fit. For example, maybe you have a case of a parent who may let you do the LP. It's normal and they do not want to stay in the hospital. Everything else is okay. You are covered by the guidelines to offer a dose of antibiotics and recheck in 24 hours. In the 22 to 28 day group, just like the younger group, everybody gets urinalysis and blood cultures. Inflammatory markers are now a thing in this age, so get them. If even one is positive, LP that baby. If none is positive, there is an option not to perform a lumbar puncture. No LP means, though, that you get admitted for observation with or without antibiotics. You can let the inpatient team decide as long as Johnny still looks well to you. Basically, the only way to be bold is if you are bold and correct. So to go home, you need that normal LP, and all of the stars must align. You get IV antibiotics, and you come back in 24 hours. So to try to flesh this out, let's do some what-ifs. What if you do the LP? It's positive. Stay, get treated, nothing controversial here. What if you do the LP, it's negative, and for some reason you just want to hold off on the antibiotics? You may, as the guidelines say, hold the antibiotics, but if you hold, you have to be observed in the hospital. Again, the only way home is with a negative LP, IV antibiotics administered in the ED, and return promised on the life of everyone's mothers in 24 hours. What if, in a more likely scenario, you can't get the LP, or there is total LP negotiation breakdown? You are not getting that LP because you don't have consent and the child still is well appearing. The infant needs to stay in the hospital for observation at that point, and that is the most important part. But you can choose to give antibiotics or not. Remember, the only way home in 22 to 28-day-olds who are still well appearing with that fever is getting that LP. It's interpretable. It's negative. You give that dose of IV antibiotics and they come back in 24 hours for a recheck. All right, well, what if you do the LP, it's negative, you get antibiotics? Everyone wants the child to go home while awaiting cultures. You have a working verified phone number. They can return in 24 hours, and the parents and you, everyone feels good about this. That is the possible narrow way to escape if everyone is on board. For me, I LP all of them. I treat all of them. I admit all of them. Basically, I treat everyone under 28 days the same. But never say never, and there will be a time when what I consider optimal care is declined, and we do have evidence-based options. I personally just don't split hairs. I mean, most babies don't have much hair to split yet. Don't get me wrong, the spirit of these guidelines is to reduce harm, which could include workups and hospitalization. And it's meant to empower clinicians and parents and do the best for that infant, given what we've got, the resources that you have, the population you have, and the whole holistic encounter. The 29 to 60 day group is already more robust physiologically, and in the modern era of vaccines, this group is becoming less at risk than previous generations. So there are even more options available. In the 29 to 60 day age group, everyone gets into urinalysis, everyone gets blood cultures, and inflammatory markers. If one inflammatory marker is positive, you may perform an LP or not. You may admit or not. If you do go home, you go home after IV antibiotics, and we'll need to recheck you in 24 hours. This, of course, will differ from our previous common practice. Before the guideline, if you got antibiotics, you got that LP, or at least an attempt at one. In the 29 to 60 day old group, if none of the inflammatory markers is positive, then it's all about the urine. The logic is that you've gone from a screening process to a confirmatory process. If the urine is positive, you need not perform the LP, but it's still an option. You can go home with antibiotics and your urinary tract infection, but admission is still an option. Remember, these are still young infants with a urinary tract infection. If your urine is negative with negative inflammatory markers, you may just go home without antibiotics, but you do need a recheck. Feeling a little overwhelmed with all of these options? Me too. Let's do some what ifs for the 29 to 60 day old group to try to keep this all straight. What if one inflammatory marker is positive, say a procal of 2 or 3? You perform that LP. If it's positive, you're admitted. If it's negative, you can stay or go with or without antibiotics. Your choice. You'll just have to understand the family and your own comfort level. What if you don't have an LP result? Either you don't do it, it's refused, or you can't get it, or maybe it's just not interpretable. In this case, you should give IV antibiotics and, you guessed it, home or stay. So the path home for the 29 to 60-day-old is a bit wider. If the child has negative inflammatory markers and a negative urinalysis, you can send home with 24-hour follow-up with or without antibiotics. That would be the best case scenario of them all. If the child has negative inflammatory markers and a positive urinalysis, you have a working source and you can choose whether to go further in LP or choose whether you want to treat at home, treat in the hospital, but follow-up needs to happen in 12 to 24 hours. The follow-up here is sooner because the presence of bacterial infection is not theoretical, it's real. Infants can go from febrile UTI to urosepsis relatively quickly, and even though most don't. We just need a closer follow-up on these kids who already we know have an infection. Again, practicalities are important here. Just for reference, we used to admit babies with a febrile UTI under 3 to 4 months of age just as a precaution. Again, different hospitals will vary. In our safety net hospital, that was essential. We felt we were serving our patient population the best this way. There is better evidence now to support a possible home management strategy, but it's not a one-size-fits-all. The newer research shows that a urinary tract infection in general is not as dangerous as bacteremia and, of course, meningitis. Just a quick tangent here. We used to use the term serious bacterial illness, which is now frowned upon. The idea is that it clumped UTIs with the more serious bacteremia and meningitis. Febrile UTIs are typically associated with a more benign clinical course. For that reason, we can just talk about the specific disease entity and not use a term that represents a heterogeneous group. Another mini tangent. In adults, a positive urinalysis and fever equals pyelonephritis. The fever in adults from a urinary source connotes a systemic response consistent with an upper tract parenchymal involvement. In children, if you look at them wrong, they'll get a fever. So an infant or child may have a febrile UTI, which just means a lower tract infection and an overly active hypothalamus. Febrile UTI is a lower tract problem, treated like any other stable UTI. Pyelonephritis in children is diagnosed by ill appearance, poor perfusion, or, in retrospect, advanced imaging. In other words, the guidelines are a little freer with UTI as a fever source. It usually indicates a more benign source of fever. Any bacterial illness, of course, can lead to bacteremia, but in infants, this is not as common, although there are cases that are rare of uromeningitis. In other words, the UTI that became pyelo, that became bacteremia, that seeded the CSF. Rare, it happens, but we shouldn't let fear make us do things that won't help the majority of the population. The guidelines are trying to get us to remember that it's actually reassuring to find a UTI in a young infant 29 to 60 days old. Eureka! We found the source. Okay, we just talked about the nice, perfect case of negative inflammatory markers and what to do if the urine is positive or not. But what if one of the inflammatory markers is positive in the 29 to 60-day-old group? Well, there are options here too. Of course, we have to be more careful with a positive inflammatory marker. Something may be going on. You may perform a lumbar puncture, or, you guessed it, or not, admit or send home. In the 29 to 60-day age group, if you get the LP and it's positive, obviously treat with IV antibiotics, admit. If you get the LP, it's negative with that positive inflammatory marker, you may give IV or oral antibiotics, and you may send home. If you can't get the LP for whatever reason, you should give IV antibiotics. You have a positive inflammatory marker after all, and you can either admit or home with close follow-up. So again, this is getting a little bit jumbled and confusing real fast, so let's offer some tangible scenarios. Macy is a 35-day-old with negative inflammatory markers and eureka! She has a UTI. Her parents feel comfortable taking her home with oral antibiotics and a recheck in 12 hours. By the way, you can also just keep her in the hospital if that's how the best care is determined. Tracy is a 42-day-old girl with one positive inflammatory marker. You try to get the LP, but you can't. You give IV antibiotics and you observe in the hospital. Theoretically, you could send home after antibiotics, but given the inflammatory marker, everyone is on board with being admitted. Stacy is a 58-day-old girl with negative inflammatory markers and a negative urinalysis. Yes, maybe she is the one who can go home, but something just doesn't sit right with you. Mom and Dad are a little worried too. You realize you're completely in the guidelines to LP, so you do it. It's negative. You give IV antibiotics to be safe, again within the guidelines. They go home, but they'll have to come back in 24 hours for a recheck. Now that's a lot of algorithm writing. Instead of getting caught up in the details that you can easily look up, let's give ourselves some safety bumpers. The minimum and maximum of investigation and care, the most conservative and the least conservative approaches by age. This is just going to be a recap of what we discussed, but it's a way to really help you feel through what are the patient factors and then what your own risk tolerance is and where those come together. So, in 8 to 22 days, there is no room for debate. All infants 8 to 22 days get a urinalysis, blood cultures, lumbar punctures, IV antibiotics while we wait, and admission. No news here. Just make sure that you've thought about herpes simplex virus and treat anyone who may be at even the slightest risk of HSV. 22 to 28 days. Enter the inflammatory marker. What are they again? Temp greater than 38.5 degrees Celsius, procal of greater than 0.5, CRP of 20, ANC of 4200, ANC of 5200 if you don't have a procal. The most conservative approach for the well-appearing infant 22 to 28 days old is urinalysis, CBC, blood cultures, inflammatory markers, lumbar puncture, IV antibiotics, admit, boom, done, and identical to the 8 to 22 day group. The least conservative approach for the well-appearing 22 to 28 day old would be one of 4 scenarios. So giddy up. Scenario 1, negative blood, negative tap, antibiotics, home with follow-up. All of your inflammatory markers are negative. The lumbar puncture is done. It's interpretable. It's negative. You give antibiotics and they can follow up in 24 hours. Scenario 2, in this 22 to 28 day old group. Negative blood, tap not available, plus or minus antibiotics, but admit. So you have no inflammatory markers that are positive. That's beautiful. But you either can't get the tap or you can't interpret the tap, or there is outright tap refusal and you just don't have that information for guidance. So you have to admit in this group because you can't tell without a tap in this age range. Now, you can choose to give those antibiotics or hold them, talk to the admitting team, see how everyone feels, because this child is still doing well with those options and can be watched in-house. Scenario 3, positive blood, but negative tap, antibiotics, home with follow-up. This is similar to scenario 1, except you have a positive inflammatory marker. We are leaning heavily on a negative lumbar puncture here, but again, just an option. Scenario 4 in the 22 to 28 day old group, positive blood, tap not available, antibiotics admit. So one of your inflammatory markers is positive, you have no tap to go by, you have to just give those antibiotics and admit. This is similar to scenario 2, where you don't have that TAP available in this young age group, so you have to admit. In the 22 to 28 day old group, no TAP equals admit. Positive inflammatory marker here prompts the antibiotics, as opposed to the other scenario where there was no TAP done, but the inflammatory markers were negative, so you could choose to hold antibiotics. As you can see here, there are some very narrow paths to home in the 22 to 28 day old crowd. I offer what I think is optimal care to the parents, which is everything and admit, just like the 8 to 21 day crowd. This suits the patient population that I care for and takes into consideration their access to care. But, I would use these 4 scenarios mostly as a theoretical backup. Let's go over the most conservative and least conservative approaches in the 29 to 60 day old group. The child here is becoming more resilient physiologically, and the incidence of invasive bacterial infection is declining, so we can be a little more loosey-goosey, depending on the situation. First, the most conservative approach. The most conservative approach for the 29 to 60 day old group is urinalysis, CBC, blood cultures, inflammatory markers, and lumbar puncture. If your LP is positive, admit with antibiotics. If you have a UTI, then admit antibiotics. If you have an abnormal inflammatory marker, admit IV antibiotics. You're covering all your bases. The conservative route also covers you to send the 29 to 60 day old home when you have a normal urinalysis, your inflammatory markers are negative, your CSF is negative, you can give those antibiotics and have them return in 24 hours. You've done all the things. They're all normal. You're giving the IV antibiotic, and it is okay for them to come back. In other words, do everything in a conservative approach for the 29 to 60 day old. If anything is positive, admit with antibiotics. If everything is negative, give those antibiotics just in case you may have some occult bacteremia, and have them follow up in 24 hours. As we mentioned, this was actually the strategy we used for the 2 to 3 month old in the past. The advancement here is that we can use this approach very conservatively, now down to 29 to 60 days. I've done this a few times recently, and I'm still getting used to it, but this is a safe and sound approach. Okay, let's talk least conservative approach for the 29 to 60 day old. By the way, I say least conservative with no qualification at all. Doing less is sometimes the better choice, and it all depends on the context. You can already get a sense of how I feel about the littlest ones. I'm more protective and more skeptical, but these guidelines are the best reflection of the best evidence we have out there. So I don't want to give the impression that they're less than. I feel a bit better being a bit more loosey-goosey in this older age group. So, least conservative approach, 29 to 60 days. Scenario 1. Negative blood, negative urine. No TAP, no antibiotics, home with follow-up. The idea is that you've done a pretty good screening by blood and urine, the child as well, and as long as you can see them in 24 hours, this is an acceptable approach. Scenario 2. Negative blood, positive urine. No TAP, give antibiotics, home with follow-up. Of course, you can keep a child with a positive UA, and I certainly would, but theoretically, they could go home on oral antibiotics. The caveat here is that the recommended follow-up is in 12 to 24 hours. That has to be feasible as well. Scenario 3, in the well-appearing 29 to 60-year-old with fever, so positive blood, but a negative TAP, no antibiotics, home with follow-up. The lesser conservative thing here is just no antibiotics, with the thought that if you have an interpretable negative TAP, you're going to get that follow-up, you're going to catch that person if they get sicker. Scenario 4, positive blood, TAP not available. Give antibiotics, go home with follow-up. The lesser conservative thing here is that you don't have a TAP to interpret, but you go home anyway, but only if, of course, you give that bug juice and you come back for a reeval. You can see that there are going to be some reasonable situations where you may choose one of those 4 scenarios in the 29 to 60-day-old. People come to us in all walks of life with all kinds of needs and goals and resources. Our challenge is to meet them where they are and to help them the best way we can, given our obligations to the patient as well as our desire to serve the patient and his family. So hopefully going through each of these possible scenarios helps our brains ping, ping, ping through that pinball machine that these guidelines can feel like. There is logic and a pattern to these scenarios. So let's test our knowledge and retention with a few cases. I'm going to quiz you about how to apply the guidelines. Are you ready? A 6-day-old baby boy is brought in with a fever at home. Just kidding. The guidelines don't apply here, right? Assume the worst, do your best in this child less than 8 days old, and assess for all forms of badness. A 9-day-old boy is brought in for poor feeding. When you look at him, he seems irritable. Got you again. The guideline is only for well-appearing infants. Do what you already know. An irritable infant is very concerning. Do all of the things. A 10-day-old baby girl is brought in by her mother for spitting up ×1 right after a feed. She seems well, and mom hadn't noticed anything else unusual. But you did. Her temp is 38.1 degrees Celsius. What do? It's a fever in an 8 to 22-day-old. She's well appearing. That's good. We do everything. Shock and awe. Treat. Admit. The most important thing to do in this age range, however, the thing that could slip through the cracks, remember, do a great prenatal history. Vaginal delivery, prenatal care, any concern whatsoever for herpes simplex virus, check that baby head to toe. Get her naked. Look at every little nook and cranny. I've picked up vesicles unexpectedly from time to time. When in any doubt, treat with acyclovir in addition to the usual ampicillin and either ceftazidime or gentamicin. A 23-day-old baby girl was born full term, no complications. She seemed warm, and her father took a temp, and all that he can remember was that it was high. He's anxious, but the baby girl appears well. Her temperature is 38.2 per rectum. Her vital signs are very reasonable. So what do? Enter the inflammatory marker. In 22 to 29-day-olds, inflammatory markers may help with treatment and maybe even dispo. Conservatively, do everything. But, true or false, could you have a negative urine, negative inflammatory markers, negative LP, give antibiotics, and go home with follow-up? Yes. Yes. You can go home because we checked everything and nothing was positive, and we will still cover you, and you are still coming back for a recheck. Remember, no LP, no go home. Obviously, if you have a source of infection that we find, no go home. But there is a very narrow way out. Just go back to the algorithm to check your work. A 35-day-old baby boy has a tactile fever at home and in the ED has a temperature of 38.4 degrees Celsius. He ends up having negative inflammatory markers, but a positive urinalysis. Do we need to do the LP before we give him antibiotics? No, you're not required. And it is perfectly fine to call this a febrile UTI, treat it even with or without a lumbar puncture, because this child is well, he's full term, he has no complications, he has no comorbidities. You can choose whether to manage in-house or at home with 12 to 24-hour follow-up. A 40-day-old baby girl is brought into you for runny nose, and there's a little lacy rash. She's febrile to 38.3 and has a blanchable, very benign appearing exanthem. what kind of workup do we do? This is kind of a trick question. If she were older, say 3 or 4 or 6 months old, we would just call this a legitimate source of her fever in this well-appearing vaccinated older infant. But she is only 40 days old. Even if you were to find a positive viral test, we know that we can't reliably exclude bacterial illness simply because there's a positive viral test. It's just too high risk to use Occam's razor here. So let's get to work. Like any 29 to 60-day-old, she needs a urinalysis, blood cultures, inflammatory markers. This is the loosey-goosey realm, but we can choose between conservative and less conservative approaches and still be within the guidelines. If you have increased inflammatory markers and no LP, then of course you'll need antibiotics. The core message here is viral testing can't really sway you one way or the other to determine whether you start or stop a workup. All right, you passed with flying colors. It's hard to keep all of this in our heads for now, so we'll just keep referencing the clinical policy until it is ingrained in us. The takeaway points are 3. Number 1, less than 28 days, feel free to do labs, cultures, urine, LP, IV, antibiotics, and admit. Number 2, in the 22 to 28 day group, you can start using inflammatory markers to guide whether you LP or not, admit or not. Number 3, in the 29 to 60 day group, you can use urinalysis and inflammatory markers to decide to LP or not, antibiotics or not, admit or not. That's it for the algorithms. Just a few miscellaneous points to add. As I mentioned, viral testing does not stop you from doing what you would normally do. Although the incidence of a concomitant infection is lower, it's not sufficiently low to just stop right there. Always assess the young infant's risk of herpes simplex virus, especially in that 8 to 22 day group, but really for everyone. The same goes for CSF pleocytosis. Send an HSV PCR and give acyclovir. Add Enterococcus PCR on your CSF during enterovirus season. The key to all of this is that these guidelines are here to help you. We are talking about the child who is otherwise well, and you wouldn't even think to do more if it weren't for that fever. Think things through, do what is right for the infant, for the family, and frankly, what your intuition and risk tolerance tell you to do. Don't feel bad about doing more if something does not make sense to you, but on the flip side, don't feel obligated to do unnecessary invasive things when you feel that you've done a thoughtful, careful assessment and caregivers are informed and on board. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.